talked about adrenergic drugs. Now let's talk about adrenergic blockers. Adrenergic blockers bind to the adrenergic receptors, but they inhibit or block the stimulation of the sympathetic nervous system. They have the opposite effect of the adrenergic drugs. So they inhibit or lyse sympathetic stimulation. Adrenergic blockers are also known as adrenergic antagonists, sympatholytics, alpha blockers, beta blockers, and alpha beta blockers. They're classified by the type of adrenergic receptor they block. For instance, they block the alpha 1, or they block the alpha 2 receptors, or they block the beta 1 or beta 2 receptors. When we look at the drug effects and the indication for alpha blockers, they cause both arterial and venous dilation. They reduce the peripheral vascular resistance and the blood pressure. They're usually used to treat hypertension. And the effect on the receptors on prostate gland and bladder decreases resistance to urinary outflow. So in other words, it reduces the urinary obstruction and it relieves the effects of benign prostate hyperplasia or BPH. The alpha blockers are also used to control and prevent hypertension in patients with pheochromocytoma. With Raynaud's disease, acrocyanosis, and frostbite, they improve circulation. Phentolamine quickly reverses the potent vasoconstrictive effects of extravasated vasopressors like norepinephrine or epinephrine, and it restores blood flow and prevents tissue necrosis. Remember, we talked before about with a number of drugs, we tell you to stop the drug but to leave the catheter in place. This is one of those drugs that we would give after an infiltration of epinephrine or norepinephrine. So, first question of the day. When phentolamine is used to diagnose the presence of pheochromocytoma, the nurse will assess for what indicative finding? A rapid decrease in blood pressure, steady increase in blood pressure, slower heart rate, or reduced cardiac ectopy? Well, the answer to this one is A. And the rationale is to help establish a diagnosis of pheochromocytoma, a single intravenous dose of phentolamine is given to the hypertensive patient who's suspected of having this type of tumor. If the blood pressure declines rapidly, it's likely that the patient has pheochromocytoma. Next couple slides talk about the adverse effects by body system. So if you think about these drugs as having the opposite effect as what the body system is, it's going to make a lot of sense. So for instance, with the cardiovascular system, it may cause orthostatic hypotension. Remember, these alpha blockers are decreasing blood pressure. They may cause tachycardia, they may cause edema, chest pain may ensue as well. In the central nervous system, a patient may get dizzy, they may get headache, they may have anxiety. Remember that anxiety often is a sign of things that are not going well. So remember back when we talked about hypersensitivity reactions, People they feel anxious as they start to have the hypersensitivity reaction. So the CNS often will cause people to feel anxious when things aren't going quite the right way. So in this situation, when we give the alpha blockers, they may feel anxious. There may be depression, weakness, numbness, and fatigue. Question number 2. When administering an alpha blocker for the first time, it's important for the nurse to assess the patient for the development of renal failure, hypotension, blood dysgracia, or dysrhythmias. So we just talked about this a minute ago, and the answer is B. The primary adverse effect of alpha blockers are those related to their effect on the vasculature or the cardiac system. First dose phenomena, which is a severe and sudden drop in blood pressure after the administration of the first dose of an alpha adrenergic blocker, can cause patients to fall or pass out. All patients must be warned about this adverse effect before they take their first dose of an alpha blocker. Orthostatic hypotension can occur with any dose of an alpha blocker, and patients must be warned to get up slowly from a supine position. I told you that when you go to take boards that they're going to make you know the generic names, which in this particular case is phentolamine. But when you go to work in the hospital, a lot of times the nurses and the doctors are going to be talking about the medications based on their brand name, which in this case is Regitine. Um, and phentolamine is an alpha blocker that reduces peripheral vascular resistance and is also used to treat hypertension. So think about the body, and if you have constriction of your peripheral arterioles, then it's going to be harder for the heart to pump through those vessels, which is what's causing the high blood pressure. So when we give phentolamine, it's going to decrease that resistance, and so that's going to make it easier for the heart to pump the blood through them. It's also used for the diagnosis of pheochromocytoma, which we've already talked about in that one question. It's most commonly used to treat the extravasation of vasoconstricting drugs like norepinephrine, epinephrine, and dopamine. Also, dobutamine. It's contraindicated in known hypersensitivity, myocardial infarction, and coronary artery disease. Tamsulosin, or Flomax, which you may have heard this drug on TV, is an alpha blocker that's used primarily to treat BPH, and it's exclusively indicated for male patients. Obviously, women don't have prostates, so that sort of takes care of that issue. Its contraindication is obviously a known drug allergy and concurrent use of erectile dysfunction drugs like sildenafil. Adverse effects include headache, abnormal ejaculation, rhinitis, and others. One of the reasons that you don't want to use it with sildenafil is sildenafil actually causes a relaxation of the blood vessels. And so that allows the blood to flow better into the penis for an erection because sildenafil is used for that. And so if you give Flomax, which is also improving blood flow, then you could have a person have very severe hypotension. So you've heard us talk a little bit about beta blockers, either on a test question or just recently in one of the lectures. And what beta blockers do is they block the stimulation of beta receptors in the sympathetic nervous system. And they compete with norepinephrine and epinephrine. Remember, norepinephrine and epinephrine are part of our normal hormone system. Beta blockers can be selective or non-selective. Cardioselective beta blockers, or beta 1 blocking drugs, are those. The non-selective beta blockers block both the beta 1 and beta 2 receptors. Beta 2 receptors are located primarily on the smooth muscles of the bronchioles and the blood vessels. Beta blockers that block the intrinsic sympatomimetic activity, yeah, it's a word that really you got to get your mouth around, are things like acetabuterol, penbuterol, and pindolol. They not only block the beta adrenergic receptors, but also partially stimulate them, which seems like something that you shouldn't have happen, but yet it happens. The carvedilol and labetalol are alpha receptor blocking activity, especially at higher doses. I want you to notice that beta blockers end with this OLOL, or, let's laugh about it. And so that's one way to remember what the beta blockers are, is that they've got this OLOL at the end. So just a little reminder in how the drugs work with it. Remember that the beta 1 receptors are located primarily on the heart. So the beta blockers that are selective for those receptors are called cardioselective beta blockers. The beta 2 receptors are located primarily on smooth muscle of the bronchioles and on the blood vessels. So let's talk about how they work. The cardioselective beta blockers, the beta 1s, reduce the sympathetic nervous system stimulation of the heart. They decrease heart rate. They prolong the SA, or the sinoatrial node, recovery. They slow conduction rate through the AV node, and they decrease the myocardial contractility, thus reducing the myocardial oxygen demand. Lots of big words there on that one especially, but if you think about it, if the heart is not contracting as hard, then it's not going to need as much oxygen. So especially after a heart attack, we want to decrease the amount of oxygen that the heart is needing because it decreases its metabolic demands. So by decreasing the oxygen demand, we improve the blood pressure, especially if we've got high blood pressure. And that's what these drugs are used for. The non-selective beta blockers, the ones that affect beta 1 and beta 2, they cause the same effects on the heart as the cardioselective beta blockers, but they also constrict the bronchioles, resulting in narrowing of the airways and shortness of breath. They produce vasoconstriction of the blood vessels, and they have other effects as well. This is a list of some of the non-selective beta blockers. Again, notice that they end in LOL. And so that's a really prime way for you to pick them out. Propranolol is probably one of the drugs that you'll see a lot. Labetalol is another one that you see fairly frequently. You also see the carvedilol fairly often, and actually the timolol I've seen fairly often as well. The other ones, yeah, you see them, but not quite as often. Of the cardioselective beta blockers, I think atenolol is probably one that is used the most. Metoprolol is also used fairly often. The other ones kind of come and go. I've seen a fair amount of esmolol, but obviously you may see any or all of these in your clinicals. The indications for beta blockers are angina. It decreases the demand for myocardial oxygen. So if people are having chest pains, they may give them a beta blocker because it allows more blood flow to the muscle of the heart and it decreases the myocardial oxygen demand. Cardioprotective, because it inhibits stimulation from the circulating catecholamines. It blocks those catecholamines, so then that makes it so that the heart is protected. With dysrhythmias, specifically class 2, and it's a class 2 antidysrhythmic. With migraine headaches, the lipophilicity allows entry into the CNS. So basically what that means is they're able to attach to lipids that are circulating into the blood, and by being attached to them, it's able to cross the blood-brain barrier into the CNS. And what I can tell you from a personal level is they put me on propranolol for a while because I was having very frequent migraine headaches. And what it does is you take it every single day and it helps to decrease the number of migraine headaches that you get. And it worked pretty good for me until I started having some side effects. And if you want to know about those side effects, we'll talk about that later. Question number 3. A 58-year-old patient is recovering in the intensive care unit after a myocardial infarction. The nurse notes an order for the beta blocker metoprolol or Lopressor. The purpose of this drug is to dilate the coronary arteries, inhibit stimulation of the myocardia by circulating catecholamines, C, providing a positive inotropic effect, or D, maintain the patient's blood pressure. Well, we've just talked about this and how this drug may be a cardioprotective drug. So the answer to this one is B. Studies have shown increased survival in patients giving metoprolol after experiencing a MI. Metoprolol has a cardioprotective effect by decreasing the heart's response to circulating catecholamines resulting from the MI. Remember, MI, the myocardial infarction, is going to be causing an inflammatory response. And so with the inflammatory response, we have release of catecholamines. And so those catecholamines are going into the heart muscle and they're causing scarring of the heart muscle. So with this, it's decreasing the effects of those catecholamines that are causing scarring, is also causing constriction of the blood vessels in the heart. Other indications include as an antihypertensive. Um, some people respond very well to them. We'll talk a little more about some of the side effects and why you might not want to be given a beta blocker. And then for heart failure and for glaucoma, we use it as a topical use as an eye drop. The next two slides talk about adverse effects. So I'm going to let you just review those two slides, but cardiovascular wise, it can cause atrial ventricular block, it can cause bradycardia, it can cause heart failure. In the CNS, again, we can get dizziness, depression, unusual dreams, and drowsiness. This is where I'm going to talk about my propranolol experience. Um, it caused me not to get so much unusual dreams, but very vivid dreams. They were so vivid that I would sit up in bed and think that I was packing a suitcase, and I literally would be moving my hands from one side where I thought in my dream I was picking up a shirt and moving my hands over to the other side of my body to pack it in a suitcase. And eventually I started walking in my sleep. And I had never walked in my sleep before. Um, and so what happened when I started walking in my sleep is we had moved into a house with a very steep staircase. And once I started doing things where I was getting out of my bed, that became really scary. And I talked to my doctor about it, and she basically said, yeah, it's one of the side effects of propranolol is very vivid dreams. And obviously for you, it actually meant that you started doing something that you had never done in your life before, and that was sleepwalk. So yeah, they had to get me off of that medication so for my own safety so I wouldn't go falling down a flight of stairs. So here's our next question. A patient with type 2 diabetes is taking a beta blocker as part of treatment for hypertension. Which complication is most likely to develop? Hypertension, hyperkalemia, hypoglycemia, or angina? So obviously, when we look at a question like that, we have to think about the type of patient that it's addressing. It's a diabetic. And so the correct answer on this is hypoglycemia. And the reason why is that beta blockers may mask the signs and symptoms of hypoglycemia. Again, how they affect those catecholamines. So we want to make sure that people with diabetes are very careful about monitoring their blood sugar if they're also on a beta blocker. Other adverse effects that may occur with beta blockers is that with the non-selective beta blockers, they can interfere with the normal responses to hypoglycemia. So the patient won't get tremor, they won't have tachycardia, and they won't have nervousness because these beta blockers actually cause you to have a low heart rate. And so the tachycardia doesn't happen. They don't feel that nervousness because everything is all calm and wonderful. They may mask signs of hypoglycemia, so we need to use them with caution with patients who have diabetes. Atenolol, or tenormin, is a cardioselective beta blocker. It's commonly used to prevent future heart attacks in patients who have had one. It's also used for hypertension and angina, and for the management of thyrotoxicosis to help block the symptoms of the excessive thyroid activity. Atenolol is available for oral use and usually is given orally. Carvedilol, or Coreg, is a non-selective beta blocker. It has alpha-1 blocker responses. It's also a calcium channel blocker and possibly an antioxidant. It's used for heart failure, hypertension, and angina. It slows the progression of heart failure, and it also decreases the frequency of hospitalizations in patients with mild to moderate class 2 or class 3 heart failure. It's most commonly added to digoxin, furosemide, and angiotensin converting enzyme inhibitors when used to treat heart failure. Esmolol, or Brevibloc, is a very strong, short-acting beta-1 blocker. Its primary use is in acute situations to provide rapid, temporary control of the ventricular rate in patients with supraventricular tachydysrhythmias. And it's administered IV. So this question is a little bit trickier, and it's one that you have to think through. The nurse knows that the adverse effects of a non-selective beta blocker are likely to be the most immediately life-threatening in which patient. Now I'm going to go through these backwards so that we end up with the one that is affected the most. The patient with hypertension, we can rule that out right away because we give these drugs for patients with hypertension. So it's not going to be immediately life-threatening for them. A patient with gastroesophageal reflux disease, it may actually make them have worse reflux disease, but that's not going to be life-threatening. A patient with type 1 diabetes, yeah, they may have problems with hypoglycemia, but in most cases, their problems with hypoglycemia are not going to be life-threatening, even though these drugs may mask the symptoms of their hypoglycemia. However, the patient that has asthma, they're going to have a potential of having bronchoconstriction. Remember, that's one of those adverse effects that's associated with beta blockers, is that they can cause bronchoconstriction. Well, somebody who has asthma already has bronchoconstriction to the point that they're taking the adrenergic drugs to relax um, their bronchoconstriction. So they are the ones that have the potential to have an immediately life-threatening event. Look at the nursing implications. We want to make sure that we assess for allergies and histories of COPD, hypotension, cardiac dysrhythmias, bradycardia, heart failure, and other cardiovascular problems, because any of these pre-existing conditions might be exacerbated by the use of these drugs. And so that would make it a contraindication for beta blocker use. We want to remember that alpha blockers may precipitate hypotension. We're using them for hypertension, but it may actually cause them to become hypotensive. So we want to do things that will protect our patients, have them move slowly, things like that. We want to remember that some beta blockers may precipitate bradycardia. Things like propranolol, for instance, actually will slow down the heart rate, and if the heart rate is too slow, we don't want to give the medication. May cause hypotension, heart block, heart failure, and, as we've talked about before, potentially bronchoconstriction. So I want to point out that in the previous slide we talked about COPD. Both COPD and asthma are respiratory problems that we don't want to have bronchoconstriction with. So we want to watch our patients that they may have symptoms of this. We want to teach our patients to avoid over-the-counter medications because of possible interactions. Many things like antihistamines and cold medications may cause constriction of the blood vessels. And if we're giving medications that are trying to lessen that, we basically are making their therapeutic drug not work. So that's why we want to avoid these over-the-counter medications, or have the doctors recommend which ones of these over-the-counter medications they can use. Some of the possible drug interactions that can occur with beta blockers include antacids, antimuscarinics or anticholinergics, diuretics and cardiovascular drugs, neuromuscular blocking drugs, and oral hypoglycemic drugs. So as we're learning more and more about these different kinds of drugs, think about what these drugs do. So with the oral hypoglycemic drugs, the beta blockers may cause hypoglycemia, or they may mask the effects of or the symptoms of hypoglycemia. So you would be more likely to have hypoglycemia. With the diuretic and other cardiovascular drugs, it may potentiate or may work against those drugs. So we want to make sure that we're not giving drugs where there's potential interactions. We want to encourage patients to take their medications as prescribed. You would be surprised how many people will go around and say, well, I don't think I really need the whole dose. I'll just take part of the dose. If the doctor gave you that dose, they gave you that dose for a reason. And I can speak to this on a real personal level. My mother was a nurse. She knows good and well that you ought to be taking the medications as ordered. However, my mom will do things like, well, my blood pressure hasn't been that high, so I only took half of a pill. And it's like, Mom, you know better than that. So we need to make sure that we strongly encourage our patients to take their medications as prescribed. We want to instruct patients that these medications should never be stopped abruptly. These medications have to be weaned off. When the doctor decided that I needed to when the doctor and I decided I needed to come off the propranolol, there was a weaning period where slowly but surely She decreased the amount of propranolol that I was receiving. If you come off of it too quickly, you can get a surge and actually end up with really bad hypertension. You want to inform the patients to report constipation or development of urinary hesitancy or bladder distension. These drugs can affect the smooth muscles of the GI system or the urinary system. As I mentioned in the previous slide, rebound hypertension or chest pain may occur if these medications are discontinued abruptly. You want to instruct the patients to notify their physicians if they become ill or if they're unable to take their medication. Because think about it, that would be this: if somebody's vomiting, they wouldn't be able to take their oral medication, and it would be the same as them abruptly stopping their medication. You want to inform patients that they may notice a decrease in their tolerance for exercise. So they might become dizzy or faint or feel faint with increased activity. And you want them to notify their physician if these problems occur. You want to teach patients to change their position slowly to prevent or minimize postural hypotension. It has a tendency to get better after they've been on the medication for a while, but especially when they first start taking these medications, they may notice a very strong postural hypotension. You want to instruct the patients to avoid caffeine because that will prevent them from having excessive irritability. You want to instruct the patients to avoid alcohol ingestion and hazardous activities until their blood levels become more stable because of this uh, hypotensive reaction of these drugs. You want to also instruct them to notify their physicians if they have heart palpitations, dyspnea. Remember how it constricts the uh, the lungs, nausea or vomiting when taking their medications. We want to monitor for adverse effects. We also want to monitor for therapeutic effects. So if a patient is taking it for angina, they should have decreased episodes of chest pain. Um, they should be monitoring their blood pressure at home. So we should be seeing their blood pressure returning to normal blood pressure levels. We also want to monitor their heart rate. If they're having tachycardia, it should bring their heart rate down to normal. However, since it can also cause bradycardia, we want to make sure that their heart rate isn't too low. So we want the patient to monitor both their blood pressure and their heart rate. And then there's other specific effects that we may monitor depending on what we're using it for. Finally, we want to inform patients to report the following things to their physicians. If they have a weight gain of more than 2 pounds in one day or 5 pounds in 1 week, because that would indicate that they were retaining fluids. Now, ladies, I know that often women have fluctuations in their weight of 1 to 2 pounds because of fluid shifts that are associated with hormonal changes. That's why they have the 5 pounds in 1 week, because most women's weight with their menstrual periods don't change by 5 pounds in a week. It changes by about 2 to 3 pounds. So that's why we have the 5 pounds in 1 week. They should notify their physicians if they see edema in their feet or ankles. Again, this would be indicative of them retaining fluid. If they have shortness of breath, obviously that's associated with that bronchoconstriction. If there's excessive fatigue or weakness, or if there's syncope or dizziness, and syncope is passing out, fainting, or dizziness. They need to talk to their doctors about it. They may be on too high of a dose, and the doctor just needs to adjust the dose so that they're able to take it and not have these side effects.